moderate and lead us to the next session. Thank you. Please welcome him as he comes.
Thank you very much, Juliet, and thank you, distinguished colleagues, for making up to this event in this Global Digital Health Week 2023. So our session is about the electronic medical record systems, successes, experience, and challenges. As we all know, electronic medical record systems is rapidly replacing the manual paper-based systems. And not just for any reason, but because it is more efficient in the management of patient data, in providing decision support to clinicians, and in also supporting accurate and consistent data collection for use in decision and policy making. So joining me in this session are distinguished colleagues who have done particularly well in deploying and managing EMR deployments across Nigeria and beyond. Let me specially introduce Dr. Vivian Okafor, who is a family physician and a public health practitioner. She holds an MSc in public health, and she's also a seasoned civil servant with the Federal Ministry of Health. She's part of the technical team that is working around digital health space in the Federal Ministry of Health, eHealth Division, in the Department of Hospital Services. Let me invite Dr. Vivian Okafor to please join us on the podium. Let's appreciate her. You're welcome. A while ago, you heard from Nkiruka Uko. She is a health system strengthening expert at the World Health Organization of Nigeria. And I would also say that she's a smart guideline enthusiast. She has done quite a lot over the last year. She's primarily a pharmacist who graduated from the University of Nigeria, Nsukka, and also holds a master's degree from the prestigious London School of Hygiene and Tropical Medicine. She has worked around health information strengthening, health research and innovation, including digital health, working closely with the government of Nigeria and other stakeholders. She was instrumental in the development of the revised National Health Information Systems Policy 2021, the National Digital Health Policy 2021, the National Digital Health Strategy 2021 to 2025, and the National Health Research Policy. Furthermore, she has led several efforts in the country for the rational adoption and use of digital health technologies to improve health and accelerate progress towards universal health coverage. Let me specially invite Dr. Nkiruka to join us on the podium. Let's appreciate her, please. EHA Clinic has been a pacesetter in the use of digital health to improve the provision of health services across different healthcare settings within their care. I want to especially introduce George Ohia, who is the engineering lead health informatics at EHA Clinic. George is a seasoned software engineer with a focus on health informatics and an engineering lead at the EHA Clinic. He has passion for health informatics through his expertise in standards such as OpenEHR, FHIR, DICOM, SNOMED, LOIN, ICD-10 and 11, and a host of others. With a career marked by commitment to healthcare technology, George has led a team in creating an electronic medical record systems that significantly improves clinical workflows, data interoperability, and quality improvement initiatives. George's extensive knowledge of health informatics and technology, combined with his experience in agile project management and DevOps practices, makes him a vital resource for those interested in intersection of healthcare and cutting-edge technologies. Distinguished guests, let me invite George Ohia to the podium. The last person is actually joining us online, virtually. He is Chibueze Igwe. He is primarily a medical laboratory scientist who has ventured into health informatics during his youth NYSC year in the Federal Capital Territory Health and Human Services Secretariat as a digital health desk assistant at the Department of Health Planning, Research and Statistics. Chibueze has experience around deployment of electronic medical record systems and telemedicine systems around the Federal Capital Territory of Nigeria. He is very strong in statistical data analysis, visualization, data-driven methodologies, and currently he works as a digital data analyst at the NHS England. Let me welcome Chibueze Igwe, who is joining us virtually. We have the last but not the least, Gerrit Henning, who is CEO of Triforce Systems South Africa. Gerrit is deploying over 100 plus EMR in over 100 plus health facilities in Western Cape district in South Africa. Unfortunately, Gerrit could not join us today, but he has sent us a video which will be our starting point for the session. Okay, so because of time, we will not take Gerrit's presentation now. Maybe later on we will take it. So I want to ask, what exactly, let me start from Josh, what exactly motivated you into deploying electronic medical record systems in your hospitals?
Thank you very much, Ini. For us, we'll be speaking on behalf of VHA Clinics. So for us, it was a combination of a lot of factors. I will just share a little bit of experience we had during the COVID-19 intervention. As you know, our clinic was so much involved in the COVID-19 intervention. And during that time, we had to partner with a lot of other organizations that wanted us to either share data with us or send data to us. So it was a big challenge for us because for each of these partnerships, we had to basically start coding, like building new system, new features to ensure that we're able to accept the data and all of that. So learning from that experience, we decided that it's high time we built a system that is able to interact with other systems, so that we don't have to waste so much resources, building new functionalities and new features. That's how our journey into, building a standard-based EMR started. There were also concerns, with, the previous system we are using wasn't really that robust. So there were concerns regarding the quality of data being collected, So there were no standard. Example, a doctor wants to record vital signs. There was always this confusion. What should be the right data points, what should be the right data elements, So those concerns were there. And we also found out that most of the diseases, the way they were recording diseases were not standardized. And because of these and many more issues, we decided to build ourselves a solution that meets with global standards. And that's why we decided to adopt FHIR and also OpenEHR in building our EMR. Thank you.
Thank you very much, George, for the good work you're doing in the private sector. Yeah, Vivian, I would like to, I know that the Federal Ministry of Health has done tremendously well in replacing manual paper-based system with EHR, EMR across the federal tertiary hospitals. Can you just tell us what is the current state of that digitization project, and as well as what motivated you to go digital?
Thank you, Dr. Inebon. Interesting. For some time now, since after COVID pandemic struck the whole globe, each time I talk about digital health, sort of it enlightens my mood, because COVID brought to bear the need for digitizing healthcare. And before that time, Nigeria had gone digitized in various levels of healthcare, but COVID brought to bear the need and the urgency. So it went so, loud in the country. Talking about what motivated Federal Ministry of Health thinking of digitizing. Digitization, since we started talking about universal health coverage, without digitization, no one can achieve that. So I would say, basically, that's where we are stemming from. And also, in order to improve health outcomes, digitization will go a long way to help more than the traditional way of care. Having said that, you just rightly said that we have done a lot in digitizing the federal tertiary hospitals. It was well said. Before 2022, when we had about 54 or thereabouts federal tertiary hospitals, we have more than half of them, about 36 of them, that deployed one form of EMR or the other. They were at various levels. And currently we have about over 70 tertiary federal hospitals in country. More hospitals have joined the board in deploying one form of EMR or the other. But it might please to know that these EMRs deployed in these various hospitals have one pertinent issue, which is all of them are working in silos, which go a long way to undermine the volume of funds being sworn into this investment. As we are speaking now, even some hospitals that have the same vendor deploying this EMR, like vendor A has deployed to 1, 2, 3, 4, 5 hospitals. All these 5 hospitals are still working in silos. So that became an issue for us, gave us sleepless nights. Nigerian government have put in a lot of money, but were we actually reaping the benefits of these funds that we have sunk in? We see that we have not scratched the benefits. And it's simply because of this silos work that is being carried out in all our facilities. So currently, Federal Ministry of Health have now decided to be talking about the game changer, which is about harmonizing these EMRs and making them to be interoperable. Because without that, it will be hard for you to even access the data that you need for policy making and for decision making and for interventions in the health system. So currently, we have all these EMR running in various hospitals that are working in silos, but with a very great speed, I believe. We are moving towards harmonizing and making them to be interoperable so that at the federal level, there will be an overarching data layer that will help us to be able to make quick access and to inform decision at the Federal Ministry of Health. Thank you.
Thank you very much, Dr. Vivian. You've rightly mentioned the problems of interpreting multiple systems across multiple, care settings like we have in the federal tertiary hospitals in Nigeria. Yeah, and of course, creating information silos that is not allowing the use of data for planning and decision making. It's a very big challenge for a health system manager like yourself at the Federal Ministry of Health. Chibueze, what is your experience? You are a data analyst in the NHS England. What is your experience around actually aggregating data from the multiple, hospital settings and health institutions, and then using it for planning and decision making in the United Kingdom?
Thank you, Dr. Ekom, for that question. Actually, I've had the privilege of accessing data back home in Nigeria, and I've accessed data and used data over here in the United Kingdom. I have an experience in the differences between the two. There are challenges and there are successes around data sourcing, processing, and utilization over here. But I must say, the gap between the two places is wide. Take, for instance, in the United Kingdom, there are a lot of electronic health record systems which generate data footprints every minute of the day. And there are millions of data, but the stakeholders depend on the data to make informed decisions. One thing I've noticed that is peculiar with the data in this particular place is the interoperability and the seamless ability to access data from all tiers of government, from the national level, NHS England, to the secondary facilities, which is the trust, down to the ICBs, integrated care boards. The problem is not, the secret or the sources is not in the tools. But I've noticed that the secret of the sources over here in the United Kingdom is around the standard of policies and the implementation approach. All the systems speak to each other, so it makes it seamless to access data. Currently, where I'm working, there is an ongoing standardization and centralization of a lot of processes. A good example of them is before now we have Health Education England, NHS England, and NHS Digital. Recently, the three different directorates were condensed and centralized to only one, which is NHS England. This methodology helps to normalize all the data from those different sources into one. Secondly, before now, we have different methods of communication. For example, if I'm working in ABC NHS Trust, I will have at abc.nhs.uk. But recently, everybody working within the NHS have a centralized contact details, which is nhs.net. It may look as if there is a lot of fun going into it, but the gain is far bigger than the cost. For example, I may not know anybody in XYZ NHS Trust, but since I have an email, nhs.net, I can reach out to anyone working within NHS at any point. They have a target, and the target is by 2025, all NHS facilities will have access to EHR platform. And not having the two only, but they are all speaking to currently existing ones, and the new ones must meet up to a particular standard that has been established. One of the directorates, which I am working in, Central Commercial Function, have a branch, which is a digital team. That digital team came up with a framework, and that framework has with it bias guide. That bias guide spelled out standard which every tools, be it a digital hardware, digital software, or services coming into the NHS must meet before facilities will be encouraged or advised to buy them or use them. Now, what NHS England is currently doing to encourage the standardization, which is the secret behind the interoperability and the seamlessness to access all information, is that in the standard or frameworks, trust is encouraged but not forced to follow the bias guide and approved framework path, which is the route to market. And in so doing, all the tools coming into the market, we have a minimum standard, and that standard, one of the standard is NHS identifier, which is NHS number. So if you look at all these processes and approaches to digital tools, you'll find out that all of them is speaking towards having one body, one house with everyone inside, seamless access to information, and utilization of all those informations made available. Thank you.
Thank you very much, Chibueze. I think you've made a very strong point about the need to interpret systems, and also said that it's very important. You cannot interpret machines when people deploying the machines are not integrated together. They're not working together. And that's why this, we want to appreciate everyone for also making it to this event, which is an opportunity for us to discuss around the fire standards, as George has said. And then coming to fire standards, Kiru, you a moment ago, you talked a lot about smart guidelines around the translation from L1 to L2, translating narrative guidelines, you know, into specifications in the digital adaptation kit that includes decision support logics that helps physicians to make timely and, you know, efficient decisions during patient care. Yeah, WHO, of course, has brought this smart guideline, which is definitely fire-enabled, and it has capacity of supporting software developers and technologies like we have today in having codes, software codes that are in fidelity with the narrative health guidelines. I know you talked a few minutes ago, but I would like to know what is the approach that WHO wants, you know, to adopt in terms of ensuring that implementers like EHA Clinic, like I have Primate here, and a couple of other, you know, implementers seated in this hall, adopt, you know, the smart guidelines.
All right, thank you, Inyebong, for this. So I will start by saying that the WHO Smart Guidelines is actually a tool, you know, for policymakers to use to improve healthcare and optimize patients' outcome. And how is that? The Smart Guidelines provides an approach, a transparent approach to software developers. It provides standards and enables alignments, you know, to standards set by a country. And by doing so, it kind of already provides a platform for anybody, whether it is eHealth Africa or any system developer, you know, or implementer to use without fear of reproach or, you know, or not doing the right thing. Now, like I said, it is a tool. And part of the idea or the background behind the SMART guidelines, like I mentioned earlier, is to protect or ensure the fidelity of global protocols and guidelines and all that. And also, another reason is, if we come to the issue of patient records or providing patient-centric care, we see that practice management in a lot of countries, continents, of course, including ours, is not, it does not enable connection or collaboration or sharing of data at real time, like we've said. So in addition to providing this tool for the policymakers, it also targeting that situation whereby we could have a collaborative, well-coordinated platform or practice management ecosystem where data can flow unhindered, like has been mentioned by NHS. Those are possible. So the idea of WHO coming up with this is to enable all those. Now, being a tool that policymakers could use. I also liked what the NHS person said, that the tools themselves do not do the work, but it is actually the people. It's the policymakers, it is me and you. So WHO in pushing or advocating for the SMART guideline adoption in countries, one of the things it always advises or comes up with first is having like a convergence, a convergence platform, a convergence workshop where stakeholders all come together, whether a multidisciplinary stakeholder team, multi-sectoral from various sectors, everybody comes together, to look at what do we have, what do we need to improve, how do we need to do that together. And by so doing, when you are sitting there, I'm sitting there, and he is sitting there, it is easier for us to create something that will be amenable to all of us, or we will all want to work with, instead of something that is handed down to us to take. So WHO recommendation or guidance to countries in adopting the SMART guidelines, they have impregnated or have put this in the process of the implementation, where the design of which guideline to take or the adaptation that the country is going to take is done by the country and not really WHO. So in so doing, everybody will be satisfied. So, and the L2, like we said, it has 5 layers. The L1, which is where we have all the guidelines and protocols and all that. And the L2, which is where the real work is done, where the generic guideline based on the WHO global guideline is now domesticated in country by a pool of stakeholders or actors in the ecosystem, which now goes through to the L3, which is the codification of those guidelines or standards or those protocols, and then also bringing in the FIRE, which enables all terminologies and standards to come in, and then the last one. Now, for example, eHealth for Africa could have a platform or a digital intervention on electronic medical records they are doing. What could now be the Nigeria journey or the eHealth journey in supporting Nigeria to improve healthcare and patient outcome? It will now be to go back to that platform or the intervention or the software, look at it, does it meet up? If it is a platform that is being used for EMR, now for this EMR, what are the data elements or the content of that? That is going to be compared to the content that eHealth Africa and others has helped to develop or put up the content under the second layer of the data adaptation kit. They just have to tweak or update that platform they already have out there in the market or in the public being used. They update it, and that's that. The country could now decide to, what, this eHealth Africa platform has now everything that we as a country has defined or has put in our content, and therefore we can scale up.
Thank you.
So that's how WHO intends or is trying to help and standardize and improve care in countries.
Thank you, Nkiru. I'm happy to hear that WHO is going to work with public health practitioners to convert guidelines into software codes that is neutral for any kind of application. I think this is the best moment for us working in digital health interoperability. Thank you very much, Nkiru and WHO. The last one, we know that this is a connectathon and it's all about interoperability, connecting systems, all right, patient-centered systems. We've heard Graham talk about fire identifiers, capacity building, infrastructure, you know, a whole lot of things, policies and guidelines and all that. So for each of you speakers, I want you to just give me, in just 1 minute, just mention, what do you think is the single most important factor for Nigeria to achieve interoperability of digital health systems? Let me start with George.
Yeah, thank you, Ini. I think based on my experience, I think the single most important factor would be to have a standard, a standardized, data model, that defines how data should be saved and how data should be transmitted. Because of course, that was one of the reasons why we decided to adopt OpenHR and FHIR as well. So for us, that is the key, in achieving, data interoperability among healthcare providers. Thank you.
Thank you very much, Josh. Chibueze, 1 minute, please. You are muted, please. Can you unmute yourself?
Sorry about that. Yeah, from my own end, I think interoperability can easily be achieved by looking at just 3 things: data CIA, data confidentiality, integrity, and availability. If all the tools deployed maintains the minimum standard required to achieve these 3 things, we'll have a perfect system that will interoperate and speak to each other. Confidentiality, let there be stringent security measures to protect data. Let there be standardized platform like clinical coding, data analytics, and quality assurance across board. And let the data be available to everyone, anywhere, at any time. Thank you.
Thank you. Vivian?
Thank you so much. If you ask what is the singular thing we need to do in Nigeria to achieve interoperability, personally, I don't think it has one fits answer, but to make it in a sentence is to implement the global standards. And these standards, we know it cuts across so much. Identifier standards, interoperability standards, exchange standards. So there is no one that you say that is more important than the other one. If you achieve identifier standards and you do not achieve exchange standards, you're going nowhere. So for us, Nigeria, I think we have to agree, start one after the other, which one is more important to us, because we cannot do all at the same time. So we take them one after the other. Maybe we say, okay, let's look at identifier standards now, so that cut across every facility, cut across every vendor, they will build their systems looking at achieving this. Thank you.
Thank you very much. Nkiru, 1 minute.
If you ask me, I will simply say it is trust. Trust. Because, these standards or the IT platforms or technical will not do itself. It is the humans. It is us. You have to believe that I, maybe coming from WHO, have good intents, and what I'm doing is really beneficial and right. And I have to believe that UNICEF also has that good intent. All of us has to agree, first of all, that we need to do this. We are not lacking in technical expertise to go about standardization. We are not really lacking to a large extent in the investments or resources to do that. I think where our problems are doing for profit needs to be assured that they are not going to lose a profit. Public sector, everybody needs to be sure that whatever it is that they're trying to protect, they don't lose it. And then every stakeholder, especially the private sector NGOs, needs to also believe and understand that they will not be diminished. Their efforts will not be diminished. And then everybody needs to understand that we're doing it for all of us and for every single patient, every single client, every single citizen, or everybody living in Nigeria that will use healthcare services at one time or the other. Thank you.
Thank you, Nkiru. Standards, trust, privacy and confidentiality, and most importantly, all of us. Ladies and gentlemen, let's appreciate our distinguished panelists as they return back to their seats. Thank you. Okay, just being reminded that we allow the audience to ask 1 or 2 questions to our panelists before we ask them to return to their seats.
Thank you very much, Dr. Kong and the panelists. 2 quick questions from my side. The legal instruments to allow unique identifiers as a standard. And this is because not all of these are domiciled by the Federal Ministry of Health. Some of these unique identifiers are with, for example, the NIN. Are there instruments to allow us move this? Because I feel that it's a very important component. Secondly, the efficiency gains that come from EMRs. Are there examples of actual efficiency gains that we've seen, either at the tertiary health facilities or within the private sector? If it's at the private sector, who bore the cost of that efficiency? Did you translate the EMR costs to the patients? Did it have an effect on utilization? Because we need to know that we're not going to, we could suddenly increase the cost of healthcare by 100% and have it digitized, but who will use it? Who will bear the cost? We have a standard per capita cost for healthcare. We're not even meeting very little of it, and a lot of our OPs are driven by this inefficiency in service delivery. So just to understand how we're translating the efficiency gains into improved patient outcomes.
Thank you so much. It seems those questions were just pointing at Federal Ministry of Health. That's all right. Talking about the identifiers, of course, Federal Ministry of Health in all entirety of their activity never work alone. We usually work with every stakeholder that are into the space of whatever we want to do, we set out to do. So even before today, whenever we do these meetings on digital health related, of course, we invite all these agencies that have contribution one way or the other towards making it a success. Of course, we cannot do it. We have been working with them, the NIDA, NCC, and NASDA, and a whole lot of them. So it's not from us. And we look at, just like we have started talking about harmonization, we are looking at what best can work for Nigerians, because you know our peculiarity. You cannot choose just one. If you choose NIN, I tell you that maybe when you get to that rural area, a whole lot of them do not have NIN. If you choose phone number, some don't even have interconnectivity for that. So we are working on that with other players to achieve that. Then talking about the costs. Of course, for what I would say from our experience, from what we have been doing in the federal tertiary hospitals, there has not been any much difference in the cost. In fact, even patients have not noticed whatever difference that solution is, because there is a way where we're thinking of is patient friendly. You're just looking at that patient. You don't want to inflict more pain on them. We don't want to inflict more costs on them. So as per cost for EMR, we do not envisage any problem. We have not had any problem from that, though we know that to deploy EMR is very expensive, but we are very careful not to put it on the patients. So there are various ways various methods we have been trying to deploy EMR so that the patients do not cry. There has not been any of these hospitals that patients cry because of cost of deploying the EMR. So to that, I think I've given you what you needed. Thank you.
I just wanted to add to what the last speaker just said. For us, anyway, like she said, there's there wasn't any consideration of costs when we were like taking the decision to deploy a new AMR on the side of the patient. Ours was purely, how do we improve patient outcome? How do we improve the quality of care? And by so doing, if you're able to improve the quality of care, improve patient outcome, of course, there is tendency that leads to more revenue for you as an organization. It was basically based on the fact that we wanted to improve patient outcome, and have a solution that helps us make data-driven decisions. That was basically the main drivers for us implementing an EMR. Thank you.
So we have just two more questions. I think both of them are actually for the Ministry of Health online. The first question says, are there current policy frameworks for digital transformation of health records, including EMR, other digital solutions, and Internet of Things, to extend beyond tertiary health facilities to all levels of care in Nigeria?
That's Vivian.
And then we'll take one more question from the room.
Asking whether there is transformation. Please, can you take that? It's a very long one so that I don't
He's
lose
asking
that.
about policy frameworks for digital transformation.
Yes, we have policy framework for digital transformation. We know in Nigeria, we are good at making policies, but what is lacking is the implementation. We have policy frameworks, but we are looking at now new Nigeria. We are looking at trying to implement this by first of all, trying to get a good, governance in place to implement this. So we are getting there soon. I wanted to quickly ask to allay your anxiety of cost. Mind you, EMR is in a way, in fact, beneficial to the people that deployed it because it plugs a lot of leakages. So they even make more money. So they're not worried about cost. So they have more money to play around.
Dr. Vivian, please, still one more question. It says, which unit or department in FMOH has the mandate to drive this integration and interoperability?
Federal Ministry of Health, as we know, have a multi-departmental collaboration when it comes to digital health. But as it is right now, we have actually identified that when you're talking about EMR, you go to hospital services. When you want to talk about data and data-related research, you go to the Department of Health Planning, Research and Statistics. And when you want to talk about the Internet of Things, of course, you're looking at the ICT people. Thank you.
Thank you very much. One last question in the room. I think I saw this hand raised first.
All right, thank you to the panelists. My first question is to EHA Clinic, and yes, quality of care is key, right? But also access to care and also the affordability of care. And your company is already doing something great in terms of the integration to FHIR and clinical decision support system, as you highlighted. However, we know that insurance is key. In all of all these conversations, there's the BCHF fund. Most states are also implementing their own fund. So in terms from the private sector, are you engaging the insurance within the states or private insurance companies to maybe adopt FHIR for interoperability, or what exactly are you doing? Because again, if these health facilities are using EMR solutions, when again, the poor and vulnerable come to these health facilities, we want them to get access to care quickly. And again, that's also integrated to the insurance system to ensure that at least the eligibility and the likes is quickly retrieved, and they can have access to treatment. So I just want to understand what you are doing or what your organization is doing in terms of facilitating that conversation on FHIR to insurance companies. Then also for Madam Ikuruka, I think, yes, the guidelines are well aware of it, and but I just want to confirm at level 2, to me, it seems like the very important stage, because that's where you define those guidelines, define documentations, whether it's requirement documentations and the likes. But in terms of implementation, are there like templates that WHO has come up with, or reference architectures that WHO has come up with that could also assist maybe the state or federal level or facility or EMR solutions or any provider that is trying to implement this framework? Are there maybe like templates that can be leveraged?
Thank you. 1 minute answers, please.
All right. Yeah, thanks. That is a very important question. I mean, as at this moment, we are kind of building a system that will allow our insurance providers to be able to assess price lists and all of that, and that has not really been efficient. Like when a patient comes into the clinic, you spend so much time trying to validate, call the insurance company, and that is a big challenge. And I mean, one of the things we want to do is why we are here, to see how we can further that discussion and create this awareness, so that these players can come into the picture and adopt these standards to facilitate this exchange. But I want to tell you that is a real problem that we're currently facing, keeping patient waiting while you're trying to get, validation from insurance company, and that takes a whole lot of time. So yeah, we are doing that. We're trying to solve that problem by being here and, helping to champion this awareness and, see how this leads all of us to. Thank you.
Yes, you're right. The layer 2 or the L2 is the most critical component of the SMART guideline process. And yeah, it's WHO already has provided it as a template. It's generic, it already has what the global has endorsed, for countries to take in. Some countries, based on the work done so far in some countries, they did small, very minimal modifications to that generic before they went to L3 and then started putting into systems. But in some countries, it was the work done was much. They had to dive so deep, change a lot of things based on the context of a country. Now, one of the fastest way a country or an organization can adapt this quickly and put to practice is by using something existing. For example, a country that has the same socioeconomic level or, like Ghana, that's already has done for ANC and family planning and all that, as patient-centric and intervention. Nigeria or a state in Nigeria could look at what Ghana did. I would tell you that it may not be very different from what you may want to do. Just change things a bit. It's already aligned to the FIRE standard and has brought in all the other terminologies onto that standard. So you can actually go faster that way. But because we want to do like a country, let the country have its own identity in terms of what they're adapting, their data adaptation kit, may want to do it as a country first before going that way. But there are faster ways, there are architecture already, which is generic for anybody to use.
Thank you very much. Please, let's give a round of applause for our panelists. Very engaging discussion. Okay. Thank you as they go back to their seats.
Thank you.
Thank you so much. We'll move swiftly on to the next panel.